for the Buffalo Bills who had a sudden cardiac death, the cardiac arrest on the field. So I had 5 talks out of that. But so this year I'm going to talk a little bit about cholesterol stuff, and everybody knows about statins, and I think this is kind of an opportunity to talk about stuff that we do for people who can't take statins or statins don't work. And it's actually interesting to think about some of the biology that's going on. I'll take you back to high school bio and kind of talk about how we can use the cell's biology to help our patients. So one of my favorite quotes from Yogi Berra. Yogi Berra has a whole line of quotes. It's difficult to make predictions, especially about the future, but this is what we doctors try and do when we do preventive cardiology. We're trying to predict who's at risk for heart attacks, strokes, et cetera. And for the patients that we identify, especially the highest risk ones, we know that we need to do everything we can to decrease our odds of something bad happening to them. And that's where cholesterol comes in. So what increases your risk of a heart attack? Well, lots of things. Point of work. We focus a lot about cholesterol because most of the other stuff we kind of either take care of or we can't take care of. High blood pressure is not that hard to take care of. Diabetes, we're working on that. If you have a family history of heart disease and you're born with certain genes, in 2024, we can't do anything about that yet, but we're working on it. Smoking, hopefully we've gotten rid of it, a lot of it in our population, but not completely. Low level of good cholesterol is not a good thing. Patients who have autoimmune disorders like rheumatoid arthritis, lupus, psoriasis, those tend to increase your heart risk as well. And then certain genetic groups, African Americans, South Asians, et cetera. But once you get past this, we do spend a lot of time talking about cholesterol because it's one of the big things that we can work on. So just to remind everybody, HDL is good cholesterol, happy cholesterol. You want a healthy level of that. LDL is bad cholesterol, okay? Because nobody can remember the numbers or the names. They really don't mean much. But H for happy and L for lousy, H for healthy, L for lethal. Although it's not always completely straightforward. In addition to LDL, there's another particle that we've been very interested in the past few years called lipoprotein A. So all these, when we talk about cholesterol, good cholesterol, bad cholesterol, it's not a cholesterol molecule, it's a big particle. This is what LDL looks like. It's a clump of lipoprotein. So lipo means fat and protein means protein. And it's a big clump of certain proteins and a whole bunch of little fat molecules. There's another bad actor that we're concerned about called lipoprotein A, or this is how we abbreviate it, LPA. It is a bad cholesterol LDL particle with this extra tail attached, which unfortunately makes it more dangerous. It makes it more dangerous in terms of risk of heart attack and stroke, and also something called aortic stenosis, which is narrowing of the aortic valve. Even within LDL, you hear about people sometimes say, well, I have a good level of HDL, I'm safe. Well, that's not really true. I mean, it's true if you take 1,000 people and you sort them out, the people with the higher HDLs are going to have a lower heart attack risk. People with the lower HDLs have a higher risk. Same thing with LDL. There's all different types as well. There's big fluffy particles, which are kind of harder to work their way into the cell walls and in between the cells of the artery lining. And those are healthier than people having small LDL particles, even if they have the same amount of LDL. There's not an easy way to change this. What we do know over the decades, and this is a whole plot of, actually this slide is actually about 15, 20 years old. And this is a whole series of studies that were done looking at cholesterol levels and preventing heart disease. Primary prevention means preventing somebody from having a heart problem in the first place. Secondary prevention is once they've already had a heart event, they've had a heart attack, a stroke, bypass surgery, a stent, is preventing something else from bad happening to them. And on the bottom here, you have LDL bad cholesterol levels, 200 on that side, 40 down on this side. And here's the risk of something bad happening. And what you see is consistently over the years, the lower you get your LDL, the lower your risk of having a heart problem. And this is why we focus so much on it. So we've been using statins for quite a number of years, since the mid to late 80s was when lovastatin or Mevacor got released, and there's been a whole series Since then, some are still on the market, some aren't. The more common ones that we use are going to be atorvastatin, which is Lipitor, rosuvastatin, which is Crestor. Those are our workhorses. There's one called pitavastatin for people who have some side effects. Sometimes they can tolerate this one. But all of these work by preventing your liver from making cholesterol molecules. There's another drug called Zetia, generic is ezetimibe, which we use a lot of as well. This is not absorbed into the bloodstream. It prevents your body from absorbing the cholesterol that's in your food. And it kind of works like a booster for a statin. So in other words, if you're on 10 milligrams of atorvastatin, you can add Zetia and sort of get the equivalent of 20 or 40 milligrams of atorvastatin. And if people have side effects of atorvastatin, we get more bang with less potential side effects. And it's finally cheap and generic. All these are generics now, which is really kind of nice. But there are some challenges. There are some people who can't tolerate statins. They have all kinds of side effects. There are some patients who, no matter how much you give them, you can't get their cholesterol low enough, especially people who have familial hyperlipidemia, in other words, genetically high cholesterol. And then there's other issues. People have high triglycerides, and then this elevated lipoprotein A that I talked about as well. So lipoprotein A is not reduced by statins. Statins lower LDL, but they don't lower this lipoprotein A. So there's a new drug that came out about 4 years ago. They launched the drug right on the eve of the pandemic. Sometimes timing is everything. So this is something called bempedoic acid, and it's marketed as something called Nexletol, or in combination with that drug ezetimibe that prevents your body from absorbing cholesterol, it's marketed as a combo pill called Nexlizet. So when your body makes cholesterol, when your liver makes cholesterol, it goes through a whole series of chemical reactions. It's sort of like an assembly line where you're building a car, okay? And the way that statins work is they block one particular enzyme, one particular step of that assembly process. Nexletol or bempedoic acid works in a different spot along the same assembly line. So it's actually been quite effective. It's not quite as strong as the highest statins that we have, but for patients who can't tolerate statins, it's a good alternative. Unfortunately, it's a brand name, so it's not inexpensive. We also have to watch out because some people have gout issues and it'll raise their uric acid, but generally our patients have tolerated pretty well. So all these, up till now, we've been talking about how to prevent your body from making cholesterol. Another avenue that's really very exciting is helping your liver remove cholesterol from your bloodstream. You can have all the cholesterol in your liver that you want. We don't care. We don't want it floating around your bloodstream, and we don't want it depositing into your arteries and causing hardening of the arteries. So your liver not only makes cholesterol, but it has receptors to bind to cholesterol as particles as it comes along, bring them into the liver and digest them. So one strategy that we have to make these receptors work more powerfully is to block something called PCSK9, and I'll explain what this all means. But basically, it's sort of like you have a vacuum cleaner that's kind of sucking along, okay? But what we really want to do is supercharge it, right? And really let it just suck every bit of cholesterol that it can out of the bloodstream. Okay, so there's a molecule though called PCSK9. God, I'm even blanking on what it all stands for. So basically, these are the receptors that the liver makes. It binds to bad cholesterol, it brings it inside and breaks it apart. And what PCSK9 does is makes this happen. If we block PCSK9, then you recycle that receptor and you keep it using again and again to get more cholesterol out of the bloodstream. And so this is our target of therapy. So there are several drugs on the market that will attack PCSK9 and prevent it from getting in the way of these receptors working maximally. These little Ys here, these upside down, these are antibody fragments. Okay, so you hear about antibodies, immunoglobulins, and your body makes immunoglobulins to anything it meets. You know, when you get a vaccine, you're telling your body, make antibodies, make immunoglobulins to whatever you put in there. The job of them is to identify something that doesn't belong in your body, to bind to it and help your body get rid of it. Okay, and it's sort of like a lock and key. There's, you know, each chemical has a, or each drug has a particular immunoglobulin that'll work. You know, as I said, it's like lock and key, but the key for my house doesn't work in Levy's house. I tried it. I tried it. So there are a lot of injectable drugs. This is also things like, you know, some of the biologic agents like Humira and stuff that people use for arthritis. So these are antibody fragments, and this is kind of what they look like. There's another piece of the tail that a normal antibody has that they cut off, but these will bind sort of like a lock and key. So there are a couple of medications that have these antibody fragments to bind PCSK9, and again, let those receptors go to town and suck all the cholesterol out of the bloodstream. So one is called Repatha and the other is called Praluent. And they've probably been on the market about 7 or 8 years at least. You have to give yourself a shot every 2 weeks. They come in these neat little injectors. You just put it on your thigh, press the button, and it does the injection automatically. I mean, there's a lot of drugs that are like this now with, you know, these drugs are proteins, right? Immunoglobulins are proteins, so you can't ingest a protein. If you ingest a protein, your body will digest it, and the active ingredient won't get into your bloodstream. This is why, for those of you who have to take insulin, you have to give yourself a shot, because if you eat insulin, your body's just going to break it apart. That insulin molecule will not get into the bloodstream. So we got to work our way around it. So these are both readily available. People give themselves a shot every couple of weeks. They work like a charm. They really lower cholesterol beautifully, and most patients do very well with them as far as side effects. Cost is a big issue. They started out at about $1,200 or $1,400 a month. Now they're sort of down to only like $700 or $800 a month. So we have to beat the crap out of your insurance plans to get them to pony up for this. Your doctor's offices spend a lot of time beating the crap out of insurance plans to make them pony up for the drugs you guys need. More than you guys realize. But those have been really highly effective. So I'm just going to take you back to high school bio for a minute, or at least this is what they teach in bio these days in high school. Okay, and the question is, well, how does your body make a protein? So inside your cell, you have the nucleus here, and that's where your DNA is, right? That has all the coding for your genes. Okay. And when your cell decides that it needs to make a protein, it makes something called messenger RNA. That's what's in COVID vaccines, is messenger RNA. Okay, and it binds to the DNA and sort of, it creates like a matching template, so to speak. So you have.
Careful, Doctor. You do this very.
Am I making you nervous?
Yes.
Okay.
I want you to.
So, oops. So your body takes the DNA, it makes a template of it, of RNA, messenger RNA, which then goes out into this, what's called the cytoplasm, kind of the soup of the cell. It goes to a place called a ribosome, which is sort of like the assembly platform, and sets up shop here. Then all these little pieces come along. So this is called transfer RNA. Transfer RNA, it has 3 what we call bases on it and an amino acid, right? So amino acids are the building blocks of proteins. Proteins are just a long string of amino acids. And depending on which amino acids you are assembled in which sequence and how they all bind together will determine what the protein really looks like. So it sets up shop here. The transfer messenger RNA brings the amino acids over here and creates a protein. And this is the beginning of a protein here. It's pretty remarkable this happens. So there's another cholesterol medication now called Leqvio, or inclisiran is the generic name. And what this actually does is it blocks this messenger RNA from working properly. Sorry. So it gets into the cell and it has a piece of RNA on it, and it binds to the messenger RNA that your body has so that your body can't make a protein from that pattern. Okay? And this is how your cells are stopped from making PCSK9. You could, if you're clever enough, you could probably do this for any type of messenger RNA. They've targeted the PCSK9. The nice thing about this is that you get a shot initially, you get a shot at 3 months, and after that, it's every 6 months, which is nicer than giving yourself a shot every other week. Yeah. Right. Yeah, just to give your muscle. The question was, do you have to give yourself a shot in different areas of your body? And the answer is yes, just because you know, it beats up your muscles when you inject them. So they usually go back and forth. I mean, you know, you give us, you know, one leg and then the other usually. So anyway, yes, this has really been great stuff. As I said, people don't have to get shots very often, and it really works to prevent your body from making this PCSK9, and therefore it really lowers the cholesterol. So this is really exciting stuff for us in terms of thinking about how we can use other drugs, not only this, but in other drugs in other areas to help our patients. And again, this is really well tolerated. We're not seeing anybody really having side effects from these injections. I never say never in medicine, but highly unlikely. And then last but not least, this is from an article in the New York Times. I don't know if you've heard of something called CRISPR, which is a gene editing technique, CRISPR. There's a give this lady, give her the door prize, right? So CRISPR technique was just approved for treating sickle cell anemia, which is a terrible disease to have. My heart goes out to anybody that has it. So actually, this is an initial study where they did 10 patients. Now, CRISPR actually goes into the DNA and will modify a small piece of it, just one little spot, and render that part ineffective or effective, depending on whether it's a defective protein, or in this case, we're trying to deactivate the protein that codes, excuse me, the gene that codes for PCSK9. So yeah, they did this study on like 10 patients. These patients were unfortunately very sick. Actually, like 2 or 3 patients died during this study. These are patients who are really kind of at the end of their line. This is like the initial study, but this has, you know, a lot of potential. I mean, they really dropped the amount of PCSK9 in the blood by down about 10% of its normal value, dropped bad cholesterol down by 60%. I mean, these are really great numbers. And this is a fix. I mean, if this works in somebody for years and years. You don't need a shot every other week. You don't need a shot every 6 months. So this is all, you know, brave new world that we're getting into, but it's really very exciting. We have the opportunity to help more and more people and fix things that were unfixable in the past. I just want to go back to this lipoprotein A for a second, because there's probably going to be a lot of this in the news in the next couple of years, and we're all excited about this. As I said, we know it's a bad actor, and as I said, statins don't work for it. So if you take a statin, yeah, you could drop your bad cholesterol by about 30–40%. Lipoprotein A, nothing. So there are new drugs on the pipeline. There's one called olpasiran. So we've already seen an article published in the New England Journal a couple of years ago that said this drug can prevent your body from making lipoprotein A and really drop the levels. That's really great news. Now the next step, which actually Honor Health is, among other places, is involved with, is we recruited patients who have high lipoprotein A, who unfortunately have already had a heart attack or a heart incident, and we're giving them this drug versus a placebo, a blank, to see whether lowering the lipoprotein A translates into what we all care about, which is preventing heart attack, preventing people from dying from a heart attack, preventing them from needing a bypass. It sounds like it should, but you know, in medicine, you got to prove it. We had drugs about 10–15 years ago that we looked at to raise HDL. Everybody says, well, gee, if you have more good good cholesterol, more HDL, you should be better off. Didn't turn out to be the case. The drugs never made it through the trials because they didn't show any benefit. So there are ongoing studies now to see if now we know that we can lower lipoprotein A through these medications, whether that will translate into a benefit for our patients. And if that's the case, stand back. I think Amgen is producing this one, but you know, don't bother trying to play on the stocks because the people in the know have already factored that in. So, and I'm the last person you want to give you stock advice. All right. Last but not least, as always, an enormous thank you to Connie and Levy.
Dr. Storch, first of all, thank you very much, and we appreciate, I learned this thing about, I don't have to deal with this yet.
Yeah.
But,
All right.
I do want to give opportunity to anyone who would like to ask a question, Dr. Storch. Let's have a few minutes.
I got a couple of minutes.
Following that, I know that it's a question that can be answered through an email about true medical advice. He has answered by email through me, so.
Wait.
I have a question about meat. Now, usually they told us you shouldn't eat red meat.
I agree.
That's so good.
I don't think people should be eating red meat, and especially not processed meats.
Okay, what about chicken and turkey?
Preferable. Chicken, turkey, and fish are preferable to red meat.
Okay. One quick one. Both my kids have LP little legs.
Yes.
Should the parents be tested for it?
It's worthwhile testing. I mean, we just test people once in their lifetime because the levels stay pretty stable. I mean, we have some patients who unfortunately have levels as high as 300, 400, 500, and we have some patients where they have a 0 level. So it's worth knowing as part of looking at your overall risk of a heart attack. I mean, it's not something you need to check every year because there's nothing that really is doing anything for it now, but everybody should know what their levels are at one point.
Okay, one quick one. Later on, is there any way to find out who's cardiologist down in Chandler or Sun Lakes? This is from a friend who's down there.
I really don't know the folks down there.
Do you have to be tested in order to know what your numbers are for all of this? I mean, I'm tested for overall cholesterol and different things of that nature, and ADL and LDL. But for these other components, is there a special test that needs to be done in order to? Okay.
Yeah. So I'll repeat the question is what other special testing is required? So a basic cholesterol profile or lipid profile is going to be total cholesterol, good cholesterol, bad cholesterol, and triglycerides. Other things like lipoprotein A. There's another thing called apolipoprotein B, which is the protein here. You know, which the amount of it is proportional to how much of these are in your system. I mean, these are all separate tests. I mean, there's an infinite number of tests that I see people get. Personally, I'm pretty conservative about it because, you know, I just want the basic numbers here, but.
What constitutes to more testing? In other words, you have your entire lipid panel done and everything else, but what would prompt you to get more testing?
Okay, so the question was, what would prompt the additional testing beyond lipid? I'm just repeating for everybody's benefit. I mean, the answer is it depends on the clinical picture here. And you know, I mean, usually I'll do that at the start when I'm trying to assess what people's status is and what their risk is and figure out a treatment plan for them. And then, you know, figure out what we're going to follow going forward. I mean, mostly the number I focus on the most because most of our patients are either have had heart problems or they're at high risk for it. So most of those people, I mean, what really matters is getting your LDL down. But we want to get the whole picture usually when we start out with folks.
Okay, thank you.
I got time. I'm sorry, but I got to go back. My office is in back north, and between the rain and the golf tournament, I'm gonna have to drive fast, or I'm gonna make patients wait. So, go ahead. You're up.
My name is Cheryl. I'm a patient with Dr. Storch. He doesn't know that I'm here today. But I have to publicly thank him because he really saved my life. And it was today. So I thank him. Then I found out he's from my hometown, Massapequa in New York. So I love him even more. We went to high school together in Massapequa. So thank you.
You're very kind. All right. Stay well and stay dry.